Thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. So for the record, please note that Elizabeth Lauro is representing Deputy Mayor Susan Miles Gustav. Karen St. Hilaire is representing Molly Wasso Park, and William Fisher is representing H. Jean Wright, all in a voting capacity. So next on the agenda is the adoption of the minutes for the Board of Directors meeting held on March 27, 2025. Are there any questions or changes? Can I hear a motion to accept the minutes?
So moved.
All in favor, please say yes.
Yes.
Opposed, say no. So the motion carries. During the executive session, the board received and approved oral and written governing body report from NYC Health and Hospitals Queens. The board also received and approved the written submission of the semi-annual governing body reports from NYC Health and Hospitals Elmhurst. The board also received and approved semi-annual governing body 2024 Performance Improvement and Evaluation Plan written submission from NYC Health and Hospitals East New York and Gotham Center. And during the executive session, the board also received, reviewed, and unanimously approved the Governance Committee recommendation to appoint Ken Rafford as Senior Vice President of Clinical Services Operations and Clinical Support Services, and Divya Pathak as Vice President, Chief Data and Artificial Intelligence Officer. Are they here?
Yes.
Yeah, they're So according to Article 6, Section C of the bylaws, committee appointments, the chair of the board shall annually appoint, with the approval of a majority of the board members to standing committees. Therefore, I would like to propose a motion to appoint Dr. Patricia Martone as chair of the Equity, Diversity, and Inclusion Committee and as member of the Community Relations, Finance, and Strategic Committees, and Vanessa Rodriguez as a member of the Equity, Diversity, and Inclusion Committee. All in favor, please say yes.
Yes.
Opposed, say no. Thank you, as always, for your service. So let me move on to Vendex approvals. Since we began the process of approving contracts prior to Vendex approvals, there are 6 items on today's agenda requiring Vendex approval. 5 have that approval. There are 22 items from previous board meetings pending Vendex approval. So we will continue to notify the board as outstanding Vendex approvals are 2025 at South Brooklyn Health. For the Bronx will be Tuesday, May 20th, 2025 at Jacobi Hospital, or Jacobi. And Staten Island is going to be Tuesday, June 17, 2025 at Seaview. Okay, so let me move on now to the resolutions. This is basically action item number 8. So authorizing New York City Health and Hospitals Corporation to name the Infectious Disease ID Center at NYC Health and Hospitals Elmhurst, the Dr. Joseph R. Massey Infectious Disease Center, further authorizing New York City Health and Hospitals Corporation to name a new training and conference support program at NYC Health and Hospital Elmhurst, the Dr. Joseph R. Massey Fund, and this was presented to the Capital Committee on April 8th, 2025.
Well, good afternoon, everyone. I'm very honored and very humble to be asking this in front of the board. New York City Health and Hospital Elmhurst is requesting to name the Infectious Disease Center and a new training conference program for the Department of Medicine for their leaders, physicians, and educators on the name of Dr. Joseph Richard Massey, who passed away sadly on November 15, 2022. Dr. Massey, on the time of his death, he was the chairman of the Department of Global Health, and he also served as the department chair of the Department of Medicine from 2002 to 2017. Dr. Massey was not only a leader in his field, but he also helped patients via education, research, books, lectures, everything from every topic from the HIV/AIDS pandemic, TB, and other infectious diseases. Dr. Massey, during the pandemic, was also our internal Dr. Fauci. He really educated us in what we could do during the pandemic. He was something always important to the decisions we were making daily with us Dr. Massey was also a professor of medicine in Mount Sinai. He was the professor of environmental medicine and a public health professor and a professor of global health. As you can see, he was a teacher and a professor not only within the walls of Elmhurst, but within the walls of Mount Sinai and in the community. He was very active in the Corona community as well. I met Dr. Massey actually when I was 18 years old in a Corona library where he was talking about HIV and he was the reason why I became an HIV counselor back then. So Dr. Massey, even from way at the beginning, was impacting people's lives in our community. That's why it's my true honor to be standing here with his family. His wife is here, Elizabeth, and his son,
Stand up.
Johnny, is here. His family has pledged $1.5 million to Elmhurst Hospital to be dedicated to the building of the ID Center and to be an additional funds to be given to the Faculty of Medicine for training and conferencing and honoring Dr. Massey's life.
Thank you. And when we do these things, in addition to the deep emotional impact, there's also, of course, the bureaucratic component. So just want to emphasize, we have followed New York City Health and Hospitals Operating Procedure number 108, which speaks to requirements for naming of a component part or one of our hospitals. And thus we adhere to the following approval processes. We received support and indeed the impetus from the Massey family to rename the Infectious Disease Center and for the new training and conference program. Obviously, as Helen said, Dr. Massey was widely known within the health system, well respected by his colleagues, by his community, by his students for decades of service. And I say that because part of the review is typically to do a background check, which makes sense. If we're going to put someone's name on something in our system, we want to make sure that that person lives up to our values. So clearly in this case, it is, are we living up to Dr. Massey's values? And again, in this process, we obtained support from the Elmhurst chair of the Community Advisory Board, the president of the medical board, and the chief medical officer, and obtained a support letter from Helen as the CEO for the renaming strategy. And again, I want to thank the family for their generosity. I want to thank Christine Morotra on my team who worked and helped sort of shepherd this through as graciously as possible. So we are bringing this resolution to the board, we did the Capital Committee for your approval, and happy to take any questions.
I'll just say Dr. Massey was a gentleman and a scholar, if ever there was one. He was an amazing guy, someone that I talked to often during COVID. He was always available, always helpful, always kind. I'm incredibly pleased that we're going to remember him in this way.
Okay, any questions or comments from board members? So let me call it for the vote. All in favor, please say yes.
Yes.
Opposed, say no. So resolution approved. Thank you so much. Okay, so I'm going to move to number 9, authorizing New York City Health and Hospitals Corporation, the system to execute standby job order contracts with Gemco Electrical Contractors and Mac Fiongile and Son Electrical, MCF, to provide electrical construction services on an as-needed basis, each for the amount of $8 million with a total not to exceed $16 million for a term of 2 years for both contracts. And this was presented to the Capital Committee on April 8th.
Good afternoon, board members, Dr. Pagan, Dr. Katz, I'm Manny Saez. Sorry.
And 10, I'm sorry. And let me do the other one too, number 10. So we'll go on them. Authorizing New York City Health and Hospitals Corporation, the system to execute standby job order contracts with Volmar Construction, Inc. to provide HVAC construction services for an amount not to exceed $8 million for a term of 2 years. This was also presented to the Capital Committee.
Good afternoon, once again, board members, Dr. Pagan and Dr. Katz. I'm Manny Sayas from the Office of Facilities Development, and I'm joined here by Menji Indar from the Office of Facilities Development. A little bit of background relative to this. This is the job order contracting and our construction contracts that are awarded based on public bid, whereby bidders use a multiplier against itemized catalogs of services to establish their their base bid solicitation and award in alignment with New York City Health and Hospitals Operating Procedure 100-5. Current electrical and mechanical HVAC contracts were awarded in 2022 and prior to expiring in December 31st of 2024 was extended by 5 months in accordance with OP 100-5 to ensure procurement of new contracts through May 31st of 2024. There is a third electrical jocks contract which will not expire until 2026. And with that, I'd like to hand it over to Menji to take us through the procurement.
Thank you, Manny. So first, we'll get into the electrical procurements. We had two bids on December 17th and December 18th of 2024. Both were for a 2-year contract. The first bid, Gemco Electrical, was the lowest responsive bidder, and for the second, McForney-Gale and Sons was the lowest responsive bidder. Next slide. This is the MWBE utilization plan for both vendors. McForney-Gale and Sons is a New York City certified MWBE, so therefore 100% of the spend on that contract will be attributed towards MWBE spend. Gemco has a 31% utilization plan. They have 5 vendors, variety of MWBEs that they will purchase parts and scheduling services from to meet the 31% goal. Next slide. This is the budget. So both contracts are not to exceed of $8 million for a total of $16 million. The next 2 slides show the vendor evaluations. Gemco is good and McForney-Gale is excellent. We'll get into the HVAC procurement now. We had 2 procurements for the HVAC as well on December 18th and December 19th. Each was opened for contracts of 2 years. HVAC 1, the vendor review process is still ongoing, and we plan to come back to the board once that process is complete for approval for that contract. For the second bid, Volmar Construction was the lowest bidder with a multiplier of 0.91. Next slide. Volmar has a 30% utilization plan with 3 vendors where they'll primarily be purchasing supplies. Next slide. And the contract is for $8 million. And Volmar currently has an excellent rating with the system. And the last slide are the resolutions again. And thank you and happy to take any questions.
Okay, so let me then take it up for a vote on the first one for the contract for Gemco and MCF. All in favor?
Yes.
Say yes.
Yes.
Opposed, say no. So resolution approved. And the next one is on Volmar. All in favor, please say yes.
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 Opposed, say no. Resolution is approved. Thank you so much.
Thank you.
So we're going to move to agenda item number 11, authorizing the New York City Health and Hospitals Corporation to execute a contract with Vernon Construction and Development LLC to convert unused C-ground space to expand the current emergency department capacity at NYC Health and Hospitals Kings County Hospital Center for a contract amount of $6,184,000 with a 15% project contingency of $927,600 to bring the total cost not to exceed $7,111,600 with an expected duration of 12 months. And this is being presented directly to the board today.
Good afternoon. Once again, for this presentation, I'm being joined by Chief Executive Officer of Kings County, Sheldon McLeod, and Chief Operating Officer, Graham Goulian. And I'll hand it over to Mr. McLeod, who will take us through.
Thank you, sir. Good afternoon, board members. So as you're looking at this slide here, as a result of the closure of the hospital that's proximal to the hospital to Kings County, we have seen an inordinate amount of increase of patients coming into our ED. Just look at 2022 versus 2024. You'll see a dramatic increase in our patient volume. You have to understand that this has created a crunch and an unsafe environment for both our patients and our staff. So we are here asking for your approval to move forward to do a full gut demo renovation of space on C ground. That is a space adjacent to the ED. Go back one more slide, please. Thank you. Space adjacent to the current ED. What you probably may ask is how would we transfer patients? We currently use that space now. Patients between those 2 spaces already exist in a safe and productive manner. What I'll do is ask Mr. Graham Goulian to just give us some more information as relates to the construction piece.
Thank you, Sheldon. So, as Sheldon mentioned, the idea is to take what is essentially the old ED from the old building and renovate additional space there. This will allow us to create a new observation unit there. And by moving the observation unit across the hall, we free up 24 bays in the old observation space. So we're netting 24 new ED exam rooms. As Sheldon mentioned, the idea is to triage patients in the ED and to move the less acute patients to this area, which will really help stem the overcrowding that we currently have in the ED, where the construction will happen. And you can see in the dark blue, that's the new observation area. And the red is where we will create these 24 additional exam bays.
And during the construction, no services will be interrupted. Patients will continue to receive service, and the construction will happen in an unoccupied area.
Another positive for us is we gained 6 negative pressure rooms in the main ED. So that will be, I think, a game changer for us, considering the environment we work in currently.
And next slide. So this is just a rendering of what the space will look like, the observation area. And this is the procurement. So in January of 2025, the procurement was posted to City Record. In February, site tours were conducted at Kings County. 23 contractors attended. In March, the bids were due, and we received 9 proposals. And on March 26th, the determination of low bid was finalized, and Vernon Construction was selected as the lowest responsive and responsible vendor for the project. Next slide. So this is the contract details. Sourced via public bid. The value of the contract is about $6.1 million. Vernon has experience in the city doing similar work for Sophie Davis Medical School, Marshak Hall, and the Queens Performing Arts Center, which is at the CUNY campus. Construction for this project is anticipated to start in the fall of 2025 and last about 12 months, so it should be completed fall of 2026. Vernon is committed to a 39% MWBE goal with 4 vendors for plumbing, electrical, demolition, and painting work. Next slide. So this is the project budget. As you mentioned, $6.1 million is the base contract. It has a 15% contingency of $925,000 for a total not to exceed amount of $7.1 million. Funded with H&H expense, and if there's a forthcoming request to authorize issuance of bonds, if approved, the expense will be reimbursed through the bond issuance. Contingency is a bit higher than our normal 10% because we anticipate higher than normal existing conditions with the space once we start demoing and doing the work. So we have a little bit of extra 5% contingency in the project budget. Next slide. And this is the resolution. Thank you. Happy to take any questions.
Any questions from board members?
I can't resist, especially there are other physicians and healthcare people pointing out, nobody really understands the increase in emergency department utilization in New York City. All hospitals are up in terms of volume of ED visits. When you look at the basic statistics for emergency room use in New York City, it's up. If you look at health and hospitals only, we are up more than the rest of the other hospitals. And I think that it's particularly notable because 15 years ago, there were none of these urgent cares that exist on almost every block now. So, I mean, one of the old things people would have said is, oh, it's because there's no access for people to go in nights and weekends for sprained ankles and bad coughs. And so now you have, I mean, I haven't tried to total, but I bet there are 300 or 400 of them, right, throughout New York City, and yet volume is up. And nobody has a very good explanation. I don't know, Michael, if you or Vince in your own practices or in your own system, but I mean, it's a very important thing for us in the future because the problem that King's is solving now, we have in several of our EDs. Elmhurst is particularly tight for space. Metropolitan is particularly tight for space. They are seeing volumes that it wasn't built for, and that interferes with patient privacy, right? It's hard to run efficiently because people are too close to one another. The costs of rebuilding these facilities can be incredibly expensive. In part because we have existing buildings and, right, you're building within a working hospital. But, for, general health policy issues, I can't, I can't exactly explain it.
I mean, I think the problem is it became a total add-on, the number of urgent care visits to what, because I think the threshold for urgent care was much less than ER. So people who weren't getting care at all, just staying at home, are going to urgent cares. There's also less availability sometimes for demand management from primary care. So there's more of a push from primary care. So I think and then of course, very often the urgent cares end up sending people to the emergency room because they need x-rays and so on, they may not have them there. So unfortunately, I think it just added tremendous amount of number of visits without decompressing, which I think was, as you know, the original thought process is that would decompress in the EDs. I just don't think that's panned out.
It's going to be a huge issue for us going forward, is how to make the existing EDs, and again, that's why I fully support this, because this is ahead of the pack in trying to be able to deal with it at Kings County. But we have several other hospitals where we don't currently have the funding in place, and often, like with, say, Elmhurst, part of the challenge is just the physical spot to do it, which is also always an issue in urban areas, right? Like, okay, you want to, but where, right? Elmhurst is a completely landlocked hospital. There's no, and again, building within a hospital that is working at caring patients is always very challenging and expensive. So with that, I fully support this.
Any questions or comments? Okay, so let's take it up for a vote. All in favor, please say yes.
Yes.
Opposed, say no. Resolution approved. Thank you so much.
Thank you.
Authorizing the New York City Health and Hospitals Corporation to execute a contract with Managed Resources, Inc. for medical necessity denial services at a not-to-exceed amount of $60,100,000, which includes a 20% contingency for a contract term of 3 years and 2 one-year renewal options exercisable at the discretion of the system. And this was presented to the Finance Committee on April 8th, 2024.
Hi, good afternoon, everybody. I'm Allison Smith. I'm the AVP of Revenue Initiatives with Revenue Cycle Services. And sitting next to me is Heather Sewell. Introduce yourself.
Good afternoon. My name is Heather Sewell. I'm the Senior Director of Clinical Denials and Revenue Cycle Services.
Okay, so I'm going to start and give you a little bit of background and our current state. So Revenue Cycle Services is seeking to engage a vendor to continue denial management and appeal services for our clinical denials. And a clinical denial is when a payer deems that the services or treatment are not medically necessary. And if H&H fails to appeal a denial, we lose all of the revenue for that admission, regardless of whether we obtain the pre-authorization or not. So we have historically lacked the bandwidth to address the full scope of medical necessity denials. The current contract that we had in place, it bridges the gap between denials appealed and in-house and that volume that we can't get to. So we're using the vendor to really supplement and ensure that we are appealing all of our appealable cases, regardless of our ability to do it in-house. The last RFP for these services was conducted in 2019 to identify denial management vendors and to manage and appeal our clinical denials. We issued the contract at that time to 2 vendors. We went with R1, CloudMed, and Managed Resources, who's the vendor that we selected this time, with a total not to exceed amount of $11.1 million, and the current contracts actually have expired on March 2025. Vendor appeals are projected to collect about 239 million through the end of the contract, and 224 million was generated as of January 2025. The spend of this contract is contingent on the funds generated. The current contract contingency rate is 12%.
City Health and Hospitals and our medical necessity denials partners, the referral rates have significantly increased. Back in fiscal year 2021, referrals ranged around 23%. That is up to 70% in fiscal year 2025. RCS originally projected 31,000 denials to be referred. However, through January, we received more than 51,000 referrals. And there were a couple of contributing factors here. First, we saw higher discharges, which led to higher denial rates and volumes. We also decided to expand the scope of work to include all United Healthcare denials and Medicaid fee-for-service as a particular pain point, and it allowed us to utilize our vendors to support us in projects and meetings. And we also added cost outliers across all facilities. So, that contributed to the higher referrals and dollars. The increase in referrals, of course, led to an increase in expenses. The projections were based on historical data from Allscripts, where we saw a reimbursement per denial projected at $6,322, whereas the actual average reimbursement per denial was approximately $21,000. At the standard 12% contingency fee, the original payment per case was projected at $759, where the actual was $2,562. In addition to that, the overturn rate ranged from 34% in fiscal year 21 to the current 43% that we're seeing in this fiscal year. So the combination of the increased overturn rate, the increased referral volume, and the increased value per denial resulted in a $17.4 million increase over the not-to-exceed contract value. However, this service is projected to collect $239 million, which represents a 738% return on investment for New York City Health and Hospitals since the contract's inception. This grid is a comparison between the original projection and the current projection. So originally, the NTE was projected at $11 million, where actuals landed at $26.8 million, with the total projection for the life of the contract to be $28.5 million. Aligned with that is the expected revenue. The original projection was $93 million. The actuals were $224 through January and will be $239 for the life of the contract. The case volume was projected at 11,600. Actuals was actually a little bit under, but due to the increase per denial volume and dollars rather, we are seeing that the average revenue brought us to $21,000 and $352 compared to the original projection of $6,322. And finally, the expected overturn rate when we started the first RFP was 37%, and we are seeing a 43% overturn rate for the current fiscal year. In terms of the RFP criteria, we were looking for a minimum criteria of 5 years in business, 3 years experience working with other similarly sized multi-hospital health systems, 3 years of experience working with Epic Hospital Billing System, $2 million in annual revenue, as well as an MWBE certification, utilization plan, or waiver. In terms of substantive criteria, feasibility and ability to meet the scope of work was weighed at 45%. Technology and reporting capabilities weighed at 30%, cost weighed at 15%, and MWBE status weighed at 10%. The evaluation committee consisted of representatives from EITS, the denials management team in finance, revenue initiatives team in finance, our managed care partners, the Office of Legal Affairs, and utilization management representatives from Elmhurst, Jacoby, and Harlem. Overview of the procurement timeline. On December 17th, the application to issue a request for proposals was approved by the CRC. December 18th, the RFP was posted on the city record and sent directly to 6 vendors. December 23rd, the pre-proposal conference was held at which 8 vendors attended. On January 17th, the proposals were due and we received 8 proposals. And finally, on January 29th, the evaluation committee submitted final scores, and below is the top scoring proposer, Managed Resources Incorporated. As the incumbent, Managed Resources was given an overall rating of excellent. Our vendor diversity team recommended a 30% diverse vendor component percentage for this solicitation. Managed Resources will utilize Review Healthcare for supplemental staffing services to satisfy the MWBE component. And would like to note that the MWBE requirement was successfully satisfied for the prior contract. Now, are there any questions?
Any questions from board members? I have a quick question connected to denials. How do you reduce denials in the first place? Are there strategies that are followed?
Absolutely.
Denials,
So we have,
maybe more of a clinical question, but
no, it's okay. I actually work quite closely with our quality colleagues under the Utilization Management Council. We have a number of initiatives in place to reduce denials, and we've been quite successful over the last few years in reducing denials. For between fiscal year 23 and 24, we actually reduced by $40 million. I'm not as certain that we're going to see the same reduction in this fiscal year, but we are continuing to find new ways to improve our documentation. We've implemented several BPAs that help our providers decide whether or not to put a patient in an inpatient setting versus an outpatient setting. We're working with AI vendors to bolster our documentation, help select the proper diagnosis. There are a number of initiatives that we believe will continue to reduce our denials.
Selecting the correct diagnosis, I think, is fascinating. We've made a lot of progress for board members. For example, if you wrote that, that the reason you were admitting the patient was chest pain, it's automatic denial, because that's a symptom.
Yes.
It's not a diagnosis.
Yes.
So if you wrote you were admitting the patient for coronary artery disease, that would be approved. But if you put down chest pain, that would not be approved. Which shows you just how arbitrary and ridiculous this is, right? Because actually what the person comes in with is chest pain, right? That is how they present, but that cannot be the diagnosis. And so there are a lot of great tools now, and the way that they're on Epic, they're not intrusive. It's not like you don't have to read something. If you put chest pain, it will tell you chest pain is not considered an acceptable diagnosis for admission. Does the patient have one of the following? And it doesn't, for obvious reasons, it doesn't choose the thing. The doctor has to choose what the patient has, but it will tell you that chest pain is not an acceptable diagnosis, and here are a set of acceptable diagnoses. Does your patient have one of these? So, it's fascinating how, the rules and the various ways that you can improve our documentation.
thank you for that. That's very interesting, how the details on that, and thank you for that. So any comments or questions on this one? Hearing none, let's take it up for a vote. All in favor, please say yes.
Yes.
Opposed, say no. So resolution approved. Thank you so much.
Thank you so much.
Thank you so much.
And let me move to number 13 in the agenda, authorizing the New York City Health and Hospitals Corporation to execute a best interest renewal contract with RightSource and Inc. for managed temporary staffing services at a not to exceed amount of 1.9 billion, which includes a 20% contingency for a contract term of 3 years with 2 one-year renewal options exercisable at the discretion of the system. And this was presented to the Finance Committee on April 8th.
Thank you. Good afternoon. My name is Yvette Villanueva, Senior Vice President of Human Resources, and I am joined here today by Micheline Farag, Senior Assistant Vice President of Finance. New York City Health and Hospitals, like other large healthcare systems, require the use of temporary staffing agency services to ensure we are properly and safely staffed at all times to deliver high-quality patient care. Rather than directly managing multiple staffing agencies and invoices, the system engages a managed service provider, what we call MSP. An MSP contracts on behalf of its client with staffing agencies, provides a single consolidated invoice, staff onboarding compliance, as well as technology to support the ordering and timekeeping processes. MSPs charge an administrative fee to staffing agencies. Right Sourcing was selected as a result of an RFP in 2019, and the system went live with Right Sourcing in September of 2020. Right Sourcing provided us over 22,000 individuals during the length of the contract. The contract expires April of 2025.
So here we are looking at our right sourcing FTE annual trends, and really I can't say anything, but this is a great story for the organization and the system. Basically, we have decreased about 52% since the peak of the pandemic, and our monthly spend by about 68%, so close to 70%. In FY25, we are projected to be slightly lower than our significantly already reduced pre-COVID agency utilization in fiscal 19. And we actually continue to reduce as fiscal 25 goes on as we head into our or complete our third quarter. In addition to our overall lower utilization, the contract renewal will actually account for the major reduction in our non-clinical agency. So there is a recalibration of how we are using temp agency, and in a very intentional way, with a major reduction in our non-clinical and right-sizing our nurse staffing models, also addressing our patient volume increase that we have encountered since pre-COVID compared to now. We have also a significant post-COVID hourly costs in the temp market that we see across the board. So this is here what you see in the graph for nursing and non-nursing comparison pre-COVID to COVID. So building on that major success that was already achieved pre-COVID, as mentioned previously, we have reduced our non-clinical areas by 80%. And this is while the system-wide volume has actually gone up in the areas of inpatient by 3%, and discharges, and over 15% in our outpatient visits. So what are some of the temp staffing cost drivers? So first, the intentional right sizing and focusing on our clinical resource needs that are required to address and support our nursing models to support our increasing patient volume. In addition, to support the hiring of our own nurses while they are in orientation, the need to support our patients as our newly hired nurses complete their orientation period, and also, of course, to fill in for any leave and support our patients during that time. The second is the need to address our staff market shortages in certain patient care and clinical support areas, for example, radiology and labs, and some other credential provider areas. As we have all seen, there's been a major national shift in the agency market and hourly costs post-COVID compared to where we were pre-COVID. Turn it over to Yvette.
The necessity of an MSP are as follows. An MSP provides consistency around regulatory and compliance standards for staffing models. A supplemental staffing mechanism allows us to maintain staffing coverage while accounting for vacancies, paid time off, intermittent FMLA, staffing initiatives, and overtime usage. Having a system-wide temp agency infrastructure in place allows for immediate activation of additional staff in the event of unanticipated emergencies. Specific roles and titles that are very difficult to recruit, especially in the cases of market scarcity. For example, radiology techs, emergency room nurses, psychiatry room nurses, etc. By working with a centralized MSP, the system has additional transparency around staffing rates. An MSP streamlines and consolidates all staffing agency efforts, which was previously managed independently across the system. Under Operating Procedure 100-5, the system can renew a contract with appropriate vendor and pricing due diligence rather than reprocure when it is in the system's best interest to do so. It is in the best interest of the system to do so for the following reasons. Staying with right sourcing ensures that the system has best-in-class services, technology, market insights, and pricing. Right sourcing provides a centralized staffing solution by contracting with staffing agencies and provides the system with a consolidated invoice, provides compliance for all temp staff onboarding, and ensures all clinical staff are properly credentialed. Right sourcing is committed to our vendor diversity policy and has agreed to meet a 40% goal over the life of the contract. Right sourcing is Joint Commission certified and have successfully supported several of our facilities with Joint Commission surveys as well as external audits. The system is also currently pursuing closeout FEMA emergency dollars associated with agency staffing for the pandemic and other emergencies. Changing the vendor at this stage could seriously jeopardize the system's closeout and reimbursement dollars in the upcoming years. Onboarding a new vendor would present a major disruption to the system-wide operations, as well as the established processes and technology integrations. Changing our staffing vendor could impact patient care if our ability to obtain temps to fill vacancies or to fill orientation time are disrupted or curtailed. A new vendor would require costly, disruptive, and other actions. For example, the rework and reestablishing of all electronic scheduling, timekeeping, and agency approval workflows and processes that are already in place. Recreating established tracking, reporting, and monitoring platforms. Reestablishing software access to Epic and other systems for proper coding. Reestablishing electronic invoicing feeds with major scale and complexity. Vendor due diligence was conducted. Right sourcing remains the premier healthcare MSP offering the highest level of service and the best technology platform. Right sourcing is the only large MSP that is vendor neutral. They do not operate a staffing agency that competes with the contracted staffing agencies. Right sourcing was able to successfully implement its services and technology during the COVID pandemic and support us to effectively manage its temporary staff and provide critical market insights. Right sourcing provides the needed mobilization capacity for quick response to unforeseen emergencies faced by the city that require us to respond urgently. Right sourcing partners with other leading healthcare providers, such as the Children's Hospital of Philadelphia, Hackensack Meridian Health, the Mayo Clinic, and Mount Sinai Health System. Right sourcing has the capacity to provide large-scale and advanced technology required by the system, which is not currently seen in the market. Pricing due diligence was also conducted. Although right sourcing does not charge the system any direct staffing fees, it does charge a 6.5 administrative fee to the contracted staffing agencies. The market standard for this fee is around 10%. Right sourcing provides national and local market rate intelligence to us. Right sourcing does not charge the system temp conversion fees and has been a key partner when operationalizing conversions of temps to employees filling our vacancies. The contract terms are as follows. Renewing with Right Sourcing, Inc. will ensure seamless continuation of best-in-class service and technology support to the system. Rebate structure will include a $6 million per year rebate for an annual minimum spend of $250 million. The rebate adjusts proportionately based on the annual spend. Total estimated rebate is valued at $30 million over the life of the contract. The proposed new term of the contract is 5 years, an initial term of 3 years, with 2 one-year options to renew exercisable at the system's discretion. The new not to exceed will be $1.9 billion, which includes a 20% contingency. This contingency would allow us to be properly positioned to respond in the event of unexpected emergencies. Right Sourcing's performance has been excellent. Under the vendor diversity category, Right Sourcing was selected during the original RFP in part because of their success in utilizing and supporting MWBE staffing agencies. Right Sourcing has been a leader in our partnership with the MWBE community. They've implemented a MWBE first sourcing model. They provide weekly training and support to MWBEs. They provide technical and financial support to MWBEs to ensure their ability to endure an economic hardship of being a small business. The prior vendor was only able to achieve 20% MWBE. Right Sourcing's success in demonstrating their commitment is demonstrated here in the chart. In FY 2021, they started off with 17%, and now in FY 2024, they are at 41%. Right Sourcing has agreed to a 40% MWBE commitment under the new agreement. Do you have any questions?
Any questions from board members?
A shout out to Danielle DeBerry and to Pete, who's here, for doing a great job negotiating the contract. Pete, thank you so much. Well done. And I was just thinking, Yvette, of what you were talking about. I want to get my labs done at Gouverneur, and there was a new person at the station, and she had a particularly nice manner. So I asked her about her history at Health and Hospitals, and she said, well, I started as a temp. And then they hired me, and I thought, it's a nice way of getting people who actually reverberate with our mission, because it's not always easy based on someone's resume or a short interview to know whether or not they're actually good. But if they actually work for you, right, then it's pretty easy to see whether or not they're good. And she was quite good.
And she will remain a committed employee to us, I'm sure.
Okay, let's take it up for a vote. All in favor, please say yes.
Yes.
Opposed, say no. Resolution approved. Thank you so much. I'm going to move now to item number 5, Executive Committee Report. So please be aware that the Executive Committee met on April 8th, 2025, and approved the following resolution: authorizing the New York City Health and Hospitals Corporation, the system, to execute a contract with Cardinal Health 200, Inc., Cardinal, for medical and surgical supply distribution for a term of 5 years with a 2-year renewal option exercisable at the discretion of the system, in accordance to OP 10005, Procurement and Contracting Policy, Article 2, Procurement Table, not to exceed amounts on goods contracts is not applicable, with annual reporting to the board. So next is the adoption of the Executive Committee meeting minutes held on April 8th, 2025. Are there any questions, comments, or changes? So can I hear a motion to accept these minutes?
So moved.
All in favor, please say yes.
Yes.
Opposed, say no. So the motion carries. Next, we're gonna move to the President's report, Dr. Katz.
You have the president's report, and except for some contract exceptions that I need to read fully into the record, I'm just gonna hit some of the top lines so people can read it on their own. We announced a new hot spotting program at Lincoln Hospital to support people who've had recent overdoses, recognizing that they're in very high risk for a second overdose after they've come in with one overdose. So this program will give them support and ongoing connection to prevent another overdose. You might think the carbon emissions only come from cars, but they also come from anesthesia machines and the deactivation of pipe nitrous oxide, and the reduced use of anesthetic gases is an important contribution that we're making to the environment. We were again on the EPIC honor roll for the 3rd year in a row for excellence in using the electronic medical record. So among people who adopt EPIC, everybody doesn't have the same level of activation of patients, of physicians, and they grade you based on how well you're using the different features that are available, and we are doing very well. Gotham opened up a MRI, which is very needed at the Broadway Clinic, and at Bellevue, we celebrated the 289th birthday of Bellevue by distributing onesies and other gifts to newborn babies. We honored 45 social workers. We honored our nurses under the Daisy Award. Metropolitan's ICU was recognized as a gold level beacon award for the critical care nurses. Dr. Suzanne Ford of Kings County was named honoree for the United Hospital Fund Excellence in Healthcare Award. Dr. Jimenez, with 2 of our board members, the Deputy Mayor, Suzanne Miles Gustav, and Dr. Michelle Morse, did hosting a session with the community and ethnic media on the New York City Care Update. We're awaiting the passage of a state budget, and we are doing everything we can to advocate against there being major cuts to health services on the federal level. Please, your patience, as I'm now going to read 4 contract exceptions into the record. So Lenox Hill Radiology and Medical Imaging Associates provides outpatient, inpatient imaging services throughout New York City. Health and Hospitals originally contracted with Remote Diagnostics Imaging 2018 for patient referrals from Bellevue. 2020, RadNet folded RDI into the Lenox Hill Radiology brand and continued to honor agreements. A subsequent contract with LHR was executed in May 2023 for the same services. That agreement is set to expire on May 31st, 2025, at which point Lenox Hill Radiology and Medical Imaging Associates, PC, would begin canceling our patient referral appointments, resulting in a critical loss in our ability to provide care to our patients. The system is in the process of finalizing a request for proposal for these services. LHR has been selected as the winner of that RFP, but we require the continuation of the current LHR contract until such time as a contract pursuant to that RFP can be signed. As a result, in order to ensure the proper continuation of care for our patients, requesting a deviation from procurement policy to extend the current contract with LHR from June 1, 2025 to April 30th, 2026, or until such time as the contract resulting from the RFP can be executed. The next one is medical necessity denials occur. This is for Cloud Med. Occur when a payer deems the services or treatment provided as not medically necessary. We just heard a presentation on that. Medical necessity denials, vendors manage and appeal denials through final resolution. This population of denials accounts for the greatest percentage of denied dollars at the health system, accruing an average of 35 million denied monthly. A gap in vendor management would result in lost opportunities to appeal denials timely, as well as delays in payment collection at R1 managed facilities. The 2025 RFP resulted in one vendor being awarded. During the transition to a single vendor, CloudMed facilities would not have sufficient coverage in the month of April to address denials. CloudMed will continue to work the open inventory until accounts are finalized, which could take up to 1 year. Due to Board of Directors and committee scheduling, the contract authorization was delayed, necessitating a deviation for the following vendor. To address the need for enough medical necessity denials vendors to address capacity, I authorized a contract exception to cover services from April 1, 2025 to May 31st, 2025. And then another medical necessity denials for Managed Resources, Inc. I explained about what medical necessity does. And again, it's the same issue about avoiding a gap. So due to the Board of Directors and committee scheduling, the contract award authorization was delayed, necessitating a deviation for the following vendor, Managed Resources, Inc. To address the need for enough medical necessity denials vendors to address capacity, I authorized the contract exception to cover services from April 1, 2025 to June 15th, 2025. And then a contract we just heard, New York's about right sourcing. We had been planning to bring it to the board for approval, best interest, which you've just heard. As a result, an extension of the right sourcing agreement is needed to ensure there's no cap in coverage until such time as the board can approve the best interest referral, which you've done, and the resulting best interest renewal can be executed, which is not yet done. To prevent an interruption in right sources work for New York City Health and Hospitals, I authorize a contract exception to cover services from April 2025 to July 2025. So you can see that in all these cases, these are all extensions for relatively short periods of time, right, so that we can bring you the correct contract. So with that, Mr. Chair, those are the contract ones that are deviation exceptions, contract exceptions.
Thank you, Dr. Katz. Any questions from board members for Dr. Katz? Okay, so let me move on to, thank you for your report.
Yes.
Committee and subsidiary reports. The committee and subsidiary reports were emailed to you and are in your electronic folders for your review and submission into the record. Are there any questions or comments about those reports? Is there any old or new business from board members to come before this board? Hearing none, the board meeting is adjourned.
Thank you.
Thank you.
This meeting is no longer being recorded.